Good afternoon. I'm Judith Levine, the director of the Public Policy Lab here in the College of Liberal Arts at Temple University. Thank you for joining us today for this webinar on the opioid epidemic. I'm grateful to be joined by an esteemed panel of experts who will share their knowledge on the nature of the problem and how best to address it. Before introducing the panel, I'm delighted that Richard Deeg, the Dean of the College of Liberal Arts, is here to welcome us to this conversation. Dean Deeg?
Thank you, Judith. It's my pleasure to welcome you today to the panel. I think it goes without saying that this is a really important topic, especially for folks listening in today. The opioid crisis is a health, social, economic, and ultimately a political problem for individuals and our whole society. Even if it doesn't get the headlines today that it did a few years ago, it still has huge impact on individuals directly and indirectly. And we're going to hear more today about those impacts. We have a great panel that provides diverse academic perspectives and research, as well as perspectives from people directly impacted by the opioid substance abuse disorder and working to reduce its prevalence and harm. I want to say that personally, I'm proud that so many Temple faculty are working on this issue, from the biological basis of substance abuse disorder to the health challenges and treatment for affected individuals, and to research-informed policy prescriptions. And in fact, the mission of PPL is to really bridge that gap between academic researchers and those working on the ground to achieve better social outcomes through better policy and practices. So accordingly, our panel today brings together academic researchers and practitioners. And on that note, I want to give a special welcome to our non-academic participants today, Congresswoman Madeleine Dean, Harry Cunnane, and Bill McKinney. I want to thank all the participants for the contributions to the report that accompanies this panel and for taking the time to be here today, and certainly for our audience that is tuning in today. I'm going to learn a lot from this, as I'm sure you will, and hopefully we'll carry that work forward. So thank you all for being here, and thank you to the panelists.
Thank you, Dean Deeg. Each spring, the Public Policy Lab publishes our magazine, which is called the Lab Report. And this year, our focus theme is the opioid epidemic. Each of our panelists has contributed an essay to the issue, and we're releasing the lab report today. We hope you'll read it. We hope you'll share it with other people who you think will be interested. The essays are really terrific, and they really strike a broad array of topics on this issue. It's now my pleasure to introduce our panelists. I am honored to welcome Congresswoman Madeleine Dean, who is the United States Representative for Pennsylvania's 4th Congressional District. Harry Cunnane is the managing partner of Ghost Pepper. Together, they are the co-authors of Under Our Roof, A Son's Battle for Recovery, A Mother's Battle for Her Son. Stephen Belenko is Professor of Criminal Justice at Temple University. Aaron Brown is Assistant Professor of Social Work at the University of Kentucky. Bill McKinney is a Kensington resident and Executive Director of the New Kensington Community Development Corporation. And Gerald Stahler is Professor Emeritus in the Department of Geography, Environment, and Urban Studies at Temple University. Thank you all for joining us. Congresswoman Dean and Mr. Cunnane, I'd like to begin with a question for you. Policy discussions that involve aggregate facts and figures often obscure the human face of this crisis. You are the co-authors of a deeply moving and extremely candid memoir that tells the story of how opioid addiction impacted your family. Can you tell us why it was important for you to share this very personal story?
Let me start by just saying thank you to Temple University, the Public Policy Lab. Professor Menace, I think, is the one who originally connected us. So thank you, Professor Menace, if you are listening in, and I hear congratulations are in order for a grandbaby who arrived, I think, only yesterday. But I'm really delighted to be with all of you. Thank you for inviting us. I think we thought it was important to tell our story, number one, because we were asked. We didn't think of doing this on our own. I was weaving it into my work anyway, because at the time of Harry's recovery. I was a state representative, and so I was weaving this into my work in terms of what I cared about and how I spoke about the issue of addiction, the disease of addiction. And you remember back in the day, we were talking about making Narcan available to families and what a controversy that was. But we were asked to tell our story. And so Harry was maybe 6 years into recovery at that point. He was always telling his story, but I said to him, "Are you okay to tell this story publicly?" I was worried, are you confident? Are you comfortable telling it publicly? And Harry asked me the same thing. "How about you?" And the answer was, "Of course." I wanted to tell it, because I'm mighty proud of Harry and the extraordinary work he's done personally, but what he's done for others. But I wanted to tell it because I knew we were not alone, that so many families are struggling with this set of issues in very different ways. Ours is only one story in very different ways. And so to get rid of the shame, to try to shed the stigma, to say, I was not immune from this. Our family did not escape this struggle. And to ask others to consider themselves, to let the shame and stigma go. Because when you do that, you actually open the door for somebody else's recovery, I believe. That's what I was thinking. Let's get rid of the shame and stigma. Let's be honest about it. Let's say who we are and show the joy of recovery.
First, it's an honor to be a part of this, with some incredible folks on this panel. Thank you for having me. Really to piggyback off of that, I'm a person in long-term recovery, and we were talking about just before we started this, this panel today. One of the things for me that was really important was 5 years into my recovery when we were asked to write our story, to tell our story publicly, and to put it out there in a different way. I recognize that even as a person living in recovery, I still was carrying that stigma and shame internally, right? For those 5-6 years, was not public about this, right? I still felt the shame that I had carried with me that prevented me from getting help for a long time, even as a person in recovery. Another thing I recognized was, when I was struggling, one of the things that held me back from wanting to, ask for help, look for resources, find an alternative to the way that I was living, was I wasn't able to easily identify people in my community or around me that were in recovery. I didn't know what that looked like. I didn't know what the pathways were. I didn't know anything about it. And because of that, I felt like I was stuck. I felt, my belief at the end of my, time using was that I was not going to be able to stop this. I had tried and tried and tried and failed and failed and failed. So when we were approached with the opportunity to write this book, it was really about, if one person can get something out of it. And I always say, our story is not a how-to story. It's not, really what it is just one family's experience with something that is, too often covered in stigma and then not talked about. This is a public health issue. We know that, this is a policy issue. But the other thing that I think is so important, is kind of the beginning part of that question. For me, my belief, is really that stories can inspire change. We need to tie them to the data, right? But, for me, the most impactful things that have allowed me to open my mind or change my perspective are the stories, right? So when we hear about over 100,000 people a year dying of overdose, and now that number has come down, while that is still something to celebrate, what I think about are the friends like Jonathan, and others that I've lost. And it's so important to remember that, that's not just one big number. These are people. And I think we need to continue to do everything that we can to bring the humanity back into this. And I believe that the numbers, the data, the research is critical to backing that up. But we need stories, not just mine, but so many others. And we need the stories out there of, where it went wrong, right? Where the outcome we know that the outcome that we've had, that I've had, is not the outcome that so many families have had that have, you know, dealt with an opioid use disorder or substance use disorder. So we need to get those out there. We need to, you know, hopefully continue to empower people. It's getting better, but continue to empower people to share stories so that we can really just bring the humanity back. I believe if we do that, we can see real positive policy changes for the better.
Well, thank you both so much, both for those answers and for your real generosity in writing the book. I'm sure it has helped many people. And I agree with you that stories are very compelling, even when the numbers are also helpful. You both talked about stigma, and I have several questions to multiple panel members about stigma a little bit later, because I think that's an incredibly important issue. But just to set the stage a little, so everyone's kind of on the same basic knowledge plane, I want to turn to Dr. Stahler. To ask, you know, before we dive deeper into this, can you just give us a bit of an overview of the history of the current opioid crisis and recent trends in opioid-related deaths?
Sure. First of all, I want to thank Judith for organizing this panel. I think it's a fantastic group of speakers, and it's such a significant issue that needs a lot more public attention. So just a few grim figures to kind of show the magnitude of the problem. So between 2003 and 2023, I just looked at these data last night, actually, close to 1.2 million Americans died from overdose. And the vast majority of those deaths are opioid related. So yes, there's been some encouraging news that, you know, there's been seems to be a decline in the number of deaths into the mid 80,000 level for last year. It's still incredibly high. I think most people, if you ask them, do you know anybody? Do you have a family member or a friend or somebody you know who has died from an overdose? I think the vast majority of people probably on this call will have known somebody. I know many people. So it's such an important issue to talk about. The number of deaths from overdose is actually higher than the number of homicides and car crashes combined. And in Philadelphia, we've been having about 1,000 people die from overdose over the last several years. And again, I think we're the third. We rate third among all cities in terms of our rate of overdose. So how did we get here? Well, the CDC talks about different phases of the opioid crisis. And the first phase, probably most people are familiar with the overprescribing of pain meds, right? So, you know, there's been a lot of films and miniseries about the Sackler family and Purdue Pharma. And so doctors were overprescribing pain meds. You know, you'd get a root canal and come home with a 30-day supply of OxyContin in the old days. Now, if you have a need for opioid pain medication, it's a lot more difficult. So we were able to kind of tamp down on the overprescribing, but at that point, you had so many people who were addicted to painkillers. What do you do when you cut off the supply? Well, suppliers are very adept at meeting demand. So that's when heroin started to really become a huge problem. So that was in the early 2010s, and that's the second phase when overdoses were started to be primarily around heroin. And that in 2015, that's when heroin overdoses began to surpass overdoses from opioids. So Philly, by the way, used to have the purest and cheapest heroin on the East Coast. And if you want to read a really compelling book about the history of how this came about, there's a book called Dreamland by Sam Quinones, which is a really terrific read. So then we come into around 2013 or so, we enter the third phase. And as the attempts to reduce heroin, become fairly good, then fentanyl comes into the drug supply, and it's a lot cheaper, more potent. It's like 40 times more potent than heroin. And so now all of a sudden, it's because of how powerful it is, you now start to see this huge jump in the number of overdose deaths. Now, around 2019, fentanyl starts to become combined with stimulants like cocaine and methamphetamine, and that's sort of the fourth phase that we're in now over the last few years. And they've also been adding to the street drug supply things like, different adulterants like xylazine, nitazines. Nitazines are 40 times more powerful than fentanyl, which is 50 times more powerful than heroin. So these are really incredibly dangerous drugs. And recently there's something called metamidines, which are out there, and xylazine, which is tranq, you've probably heard about. In fact, in the Philadelphia Health Department collected a bunch of samples routinely, and in November they found that 87% of their samples actually had metamidine in there, and 50% had xylazine. So it's an ever-changing epidemic as one type of drug kind of becomes reduced, others take its place. And one last disturbing trend is, so while recently, over the last several years, overdose deaths have been declining among white populations and pretty much still maintaining at the same level around Hispanic people, there's been just a continuing increase in overdose among Black populations nationally and in Philadelphia, particularly among older Black males.
Thank you, Jerry. It's that those are, I guess there are some heartening trends in there, but this increase in the Black population numbers are really very disturbing. Dr. McKinney, in Philadelphia, a lot of people think of Kensington as a center of having an opioid problem, and the neighborhood has also gotten national attention because of the impacts of the opioid crisis on the community. You are the leader of a community organization that's grappling with these issues very head-on. What are some of the challenges you face in trying to balance addressing this acute crisis that's happening on the streets as we speak, with the broader needs of all residents in the community?
Well, good question. Thanks for having me out here. I appreciate the dialogue that we're having today. And already some of what folks have shared has been beneficial for me to hear. I'm actually going to pull it back even a little bit further, because I think it's an either or a lot of the time, right? This question of residents versus those that are struggling with substance use disorder or being unhoused. I think it's important that even starting my comments, it's starting with, yes, I am a resident. I am the executive director of an organization. I'm also someone who's been in recovery for decades, for over 30 years. But I have a PhD in anthropology, right? And I say all of this to say, we have to get to a place that it isn't this space or that space in general, right? The intersectionality is where I really believe the solutions exist. And so that is a starting point. When we think of the community, we think of this versus that, and everyone is intertwined at this point. There is no separation that truly exists. I think it is created from the historical sort of trauma of the community, which leads to a scarcity mindset, which convinces people that we can solve one thing or the other, right? I also think that most of the solutions, whether it's for residents, long-term residents, or folks that are struggling with addiction in our area, I don't think it's the primary thing that people are trying to solve most of the time, right? I think at the end of the day, it's actually a secondary thing. Whether that is, you said it's a national story. we're a commodity, right? The story of Kensington is a commodity, whether it's for traditional press or a YouTuber who's getting $5,000 for 1 million views. A lot of the time, we're a commodity for academics. We are secondary to the publication or the promotion that is going to come from the research, rather than the primary goal being solving the problem. It can be a church, it can be someone, from church, and that they are actually dealing with their own personal salvation. And that puts, again, solving the problem as being secondary. And that might not all sound super connected, but it is, right? Like, all of these things lead to what feels like too much, right? There's too much for us to deal with. I was hearing the question, I was thinking about on Monday, I was walking to work, and it was raining, it was cold, and there was a man in the street in a wheelchair, and folks will get under the train when it's raining, because it's like there'll be 3 feet wide that you can sort of stay dry. And he was leaned over in his wheelchair to the wheel side, and he had a small fire that was entirely made of burning needles. All right. So take that image, right? And take whoever you are, whatever space you're coming from. You could be, again, it could be an academic, it could be someone from a harm reduction community, it could be someone walking their kid to school. But each one of those, where you start from, is often going to be where you're going to try and focus. Right? If you're from X community, you're going to look and go, I got to help him. I got to pull him off the street. I got to figure this out immediately. If you're that mother walking her child to school, you say, I got to get rid of this guy. This is damaging my child. Right? And I say to say all of these are valid, right? But it's your starting point. A lot of times designs where this is, and because there is this scarcity mindset at this point that we can help one or the other, right? And we're always in a triage mindset too, I would say. Everything we look at, we are in a triage mode, because there is so much suffering out there with limited resources, with limited focus, and with limited interest. Then that really becomes the biggest challenge. So I would sort of reduce it to a couple of things, which is that, like, a lot of the time the help for either or is still actually secondary. And I would say that the scarcity space that we've landed in through the traumatization of the community has led to an either or situation in most people's minds, when the answer is how I started. It sits in the intersectionality of all of this and in actual praxis. I'll stop there.
Okay, thank you. And for those who were intrigued with what you just said, your essay really spells this out further, the concept of the whole community and a holistic approach that isn't a zero-sum game. You mentioned the words harm reduction, and there's been a lot of debate about harm reduction in Kensington and elsewhere. And to get further into that issue, I want to turn to Dr. Brown. You are not only a scholar of, but also a practitioner of, as in your clinical social work practice, of harm reduction, and you are in a rural community and practice in rural communities. So can you first give us an overview of what the harm reduction philosophy is, and then I'll ask you a little bit more about urban communities.
Sure. Yeah. So harm reduction, as you mentioned, it's both a philosophy and a set of practical strategies, and it's sort of hard to define it without just repeating the words, right? But with the goal of making drug use less harmful. And it's really about this idea that any reduction in harm can be considered worthwhile, and even a success. And so reducing harm, it can be an intermediate goal, or it might even just be the ultimate goal, right? And as you mentioned, I'm a social worker, and we often talk about meeting people where they're at. And I think that's really what harm reduction is about. It's some people are not ready to stop using drugs. It doesn't mean we can't still help them use drugs as safely as possible. And rather than imposing moral judgments about drug use, harm reduction emphasizes compassion, pragmatism, and human rights. A lot of my research is focused on the implementation of medications for opioid use disorder, like methadone and buprenorphine. I see these as part of a harm reduction philosophy as well. And critics might just call them substitution treatments. And in a lot of ways, that is true. But these medications don't just replace one drug for another, they replace drug seeking with help seeking. And if you look at places like British Columbia, they offer safer supply, which means providing pharmaceutical grade opioids to people who use drugs in order to prevent overdoses due to the illicit drug supply. And as you heard earlier, that often contains toxic additives like xylazine. And in some ways, methadone and buprenorphine are a form of safer supply that we do have available in the United States. But they're also an effective treatment model where people can put their lives back together without being debilitated by cravings and withdrawals.
Thank you. And now let me zero in a little bit more on the fact that you are an expert on this issue in rural areas. In many ways, the modern opioid crisis has been most acutely felt in rural communities. And can you tell us a little bit more about why there's been reluctance to adopt harm reduction strategies, particularly in rural areas, and also whether this has been changing in recent years?
Yeah. And so, the truth is that the opioid crisis has affected all geographical regions of the United States and really all populations as well. I mean, and we spoke about earlier, there are certain groups that seem to have been more vulnerable at different times. And I think what has happened in rural areas, though, is that opioid addiction is a relatively new phenomenon. Prior to the mid 2000s, opioids, they just weren't as accessible in most rural places because prior to those drastic increases in opioid prescribings of the early aughts, heroin was the main type of opioid being used outside of medical care, and you just couldn't get heroin in rural places in most parts of the United States. So as the prescription opioids took hold in rural communities and led to addiction and overdoses, I think it's just taken time for them to learn about approaches that work. And so I think that's why rural areas have gotten more attention because it is a newer phenomenon in those areas. And qualitative research has shown that there's a lot of stigma around drug use, particularly in rural communities. It's easy to generalize, but conservative political views and religious beliefs are often more prevalent in rural areas, and a lot of the opposition towards harm reduction relies on moral views about what drug use and recovery should look like. So, what is real recovery? And of course, harm reduction, it's not just about recovery; it's about helping people use drugs safely when they continue using drugs. And so people may view harm reduction strategies as enabling, but harm reduction is not just about making it easier to use drugs, it's about making it safer to use drugs. And as a social worker, I also believe people have a right to self-determination. And whether we agree with it or not, people are going to use drugs. So why not help them do so more safely? So we want to reduce the disease burden in our communities and prevent overdose deaths. Harm reduction is definitely a part of that, but so is prevention and so is treatment, and we need all of those approaches. I think that over the last that we are seeing some change in those attitudes towards harm reduction all across the country, but particularly in rural areas. Over the last couple of decades, people have been exposed to the realities of addiction. As we mentioned earlier, I think a lot of people have had loved ones who have dealt with addiction. And so we've seen this happening in our communities. And so it's this process of gradual exposure that has helped change attitudes in rural communities. And when it comes down to it, people want their neighbors and their loved ones to be safe. They want to keep them alive. They can't afford to hold on to moral opposition to harm reduction strategies like medications for opioid use disorder when they want to meet those goals, right? And also we've seen legislative changes. So I work at the University of Kentucky, and if you have time, look up what we've done with syringe exchanges in Kentucky. I think it's really cool. We now have some of the most syringe service programs per capita in the country because they are being offered. Before 2015, they were illegal in the state of Kentucky, but we changed the law, and now they are offered in health departments all across the state, including in many rural areas. So that's pretty cool, I think. And so we're doing things like that. We're also reducing barriers to prescribing medications like buprenorphine. The Drug Addiction Treatment Act that was passed in 2000 was kind of like the law of the land for a long time, and that was I don't know if it was repealed or changed last year to now any prescriber can write buprenorphine without any additional training or any kind of status. And so that has opened up some of those barriers to buprenorphine prescribing, which is really important in rural communities because methadone is not usually available in those places. And of course, abstinence is a great way to reduce harm as well. And I think, so I want to acknowledge that and also the importance of prevention and treatment. But regardless of whether people ever achieve complete abstinence, we can help them be safe along the way as they seek recovery.
Thank you. I want to shift just a little bit to talk about the criminal legal system, and I'll turn to you, Dr. Belenko, because your essay focuses on the overlap between the opioid crisis and the criminal legal system. Can you just give us a sort of overview of what is the relationship between opioid use and the criminal legal system?
Sure, happy to do that. A number of things I'd want to mention. Given our, with the emergence of the war on drugs 50 years ago or so, under the Nixon administration and continuing under Reagan, we've criminalized drug use, and that has a couple of aspects to it. One is the enactment of many mandatory sentencing laws, which require incarceration for people arrested and convicted for possessing or selling even very small amounts of drugs. It's number one, and aligned with that is law enforcement efforts, which have focused on enforcement of trying to shut down local open-air street drug markets, where in urban areas, a lot of drug selling and possession takes place. So the impact is millions of arrests for substance use issues, including opioids, mandatory sentencing, very substantial incarceration rates, which affected communities of color to a greater extent than the majority communities. That's one aspect of it. The other is using opioids and other drugs, actively using and involving in that. And that opens people up to high risk of arrest. So whether through purchasing or possessing, again, particularly in urban and poor areas with a high likelihood of arrest. So many people are in the criminal legal system because of their substance use. So you look at some of the data, about 20% of people who are incarcerated have an opioid use disorder, 20%. That compares to low single digits in the general population. About half of people who are in our jails and prisons have a substance use disorder, generally, half. Many of them have co-occurring mental health disorders. So the prevalence of this problem within our criminal legal system is just enormous. So that story might not be so sad or concerning if we had a robust effort to actually help people who do get caught up in the criminal legal system in terms of treatment. So the other side of the story is that the criminal legal system does a terrible job of providing treatment to people who are in custody or on probation or under criminal justice supervision in any way. So very little access to treatment. People, even though a lot of prisons now, it's gotten better in terms of having some access to medication for opioid use disorder in prisons and jails, but it's still quite sporadic. Even when prison systems say they have it, it's available, but very, very small percentage of incarcerated people are able to access The treatment access is very limited. I'll come back to stigma again, and we'll talk about it a little bit later as well. There's people under criminal legal supervision suffer double and triple stigma, being substance users, opioid users, being incarcerated, having felony conviction records. Really, decks are really stacked against them. There's also stigma towards any medication that is seen as opioid substitution therapy, as Dr. Brown mentioned. So pretty much the main medication that's available to people in prisons and jails is naltrexone, or long-acting extended release naltrexone is called Vivitrol, which is the least effective of the opioid medications in terms of the research. Adherence is very poor. So many systems allow Vivitrol. When people get out of prison, they don't access it, and it's also very expensive. So it's not the best. So methadone and buprenorphine would be preferred medications, but there's that stigma concern about diversion of those medications within prison or jail facilities, et cetera. So we have a huge treatment gap in this country generally. We do a horrible, disgraceful, I'll use the term disgraceful, of how little treatment is available and how access is so difficult for people. It's especially a problem for people in the criminal legal system, where return to drug use is not just a health issue, but it opens people up to violating probation or parole and being reincarcerated. So half of the prison admissions in this country are people who violated, not new arrests, people who violated their parole, often related to their substance use. And then finally, just looking at in terms of particularly in the criminal legal system, you heard Dr. Stahler talk about, our high overdose rates. They're enormously elevated among people who've been in the criminal legal system. So people coming out of prison or jail who have histories of opioid use disorder have overdose mortality rates within the first 2 to 4 weeks of release that are 40 to 80 times higher than the general population. 40 to 80 times. The reason is they lose it, you lose your tolerance if you stop using when you're incarcerated, you stop using, you go back on the street. And if you're not linked immediately to treatment or support services, which you almost never are not, and if you return to drug use, go back to your neighborhood dealer, buy the same product, you have lost the tolerance, and overdose is highly likely.
Thank you for that. As difficult a story as that is, Mr. Cunnane, you probably a lot of those facts are things from your volunteer work. You've done a lot of volunteer work inside the prison system. Can you tell us a little bit, maybe put some of a face onto some of the trends and facts that Dr. Belenko was just laying out?
Dr. Belenko did a really good job, explaining a lot of the, the what. I'll talk a little bit, about, why, I started to do some of that, and, a little bit about what I saw. But the why is really clear, right? Like I grew up in Montgomery County, just outside of Philadelphia. I was a young kid who was, running around the suburbs and the city using drugs. With all the kind of privilege in the world, I say about my experience with the criminal justice system was that, I was treated unfairly fair. I made it through my use with no record at all. I was met with the criminal justice system and let go time and time again. So once I found myself in recovery, I knew that it wasn't me. I had every, if it was not for sort of the privilege and, my circumstances, my race, my socioeconomic background, the address on my license, all of those things, I would have or should have been somebody who was, incarcerated at some point or had a record based on the way that I was living my life in my active use. So when I found myself in recovery, it was important for me to try to do something. And, 12 years ago, and Dr. Belenko talked a little bit about some of what's offered now, it was even, kind of less in terms of, access to medications or services or anything. So it really started with just trying to, bring some peer support and, fellowship into meet with folks who were in the, really in the Philadelphia jail system over at CFCF and other places. Again, like I talked about before, it's, it's the humanity. What I saw in there is no surprise to anybody on this call, but they're just people, right? And many of whom wound up there as a result of, their drug use and a substance use disorder. So we're criminalizing a disease. And while I'm, I won't say, there's behaviors that can happen when you're using drugs that, certainly are criminal. If we look at the criminal justice system as, the solution, we've seen the war on drugs has not worked, right? And what I found over and over was so many of those people were, they were the users, not the, not the dealer, not the cartel, like not the, not what we're going after when somebody isn't enacting one of these policies with a long mandatory minimum and kind of what the rhetoric is. These are people who are, who are using drugs. And as Dr. Belenko said, so many of those are, they've served time, they got out and they continue to struggle because there's no support. They weren't given support while they were incarcerated. They were certainly not given support, whether that be treatment or otherwise after, and recurrence of use gets them jammed up with parole or probation in their back. So many of them are people that, I think it's important to know were people that were really trying to get their life back on track, right? That were, I saw so many people that had some time in recovery and found themselves with a return to use, which brought them right back into the system. And, what is so incredibly concerning is, all of it, but what happens to somebody's access to, medication, insurance, Medicaid, all of these other services that can get shut off when you're in there, and that increase in risk of death, right? Like we have seen that, and that plays a major factor in the, the death toll that we have seen as it relates to overdose, because the tolerance is gone. And again, they were removed from their environment. And, when they get out, they had no support, no treatment. And, they go back and, don't have that tolerance. So, for me, it's about, again, the humanity of it. These are people, these are our, community members, brothers, sisters, friends, parents, that are struggling with a disease and a public health issue. And, if we have them there, and they are impacted in the criminal justice system, we have, I think, an obligation as a society to provide all of the services and support that we can, because we do have, folks that are, in the care of this country, and in our community. So to not provide that is such a disservice without going into the other side of, why are we criminalizing, so many of these things. But Dr. Belenko, covered, so many of the facts that I think are just so critical, and I wish more people knew.
Thank you. Congresswoman Dean, in your essay, you, as Mr. Cunnane was just saying, you caution against a policy agenda that focuses on criminalization and this return to a war on drugs, which there is a lot of rhetoric about. In your view, what are the types of policies we should be moving towards to more humanely address the crisis and save people's lives?
Well, oh gosh, I've got so many things that I think about, and Harry and I had the chance to visit CFCF one time together, and the very thing that he's talking about, that being treated unfairly fair, as we walked around and saw and met with some inmates, I just kept thinking to myself, and any time, and I've gone to multiple different prisons and jails, I think, why hasn't every one of these folks been treated that same way? The just gross inequity in our society as to how we treat people who are struggling with mental illness and addiction. And then when you layer into that poverty and race, it is just grotesquely inequitable and unfair. So in my own work, when I was a state representative and now as a member of Congress on judiciary committees in the State House and here, I have fought against these mandatory minimums that we know do no good. They don't do anything around addiction. They don't do anything around easing crime in our society, and they just continue and perpetuate what I believe is racism and poorism and a few other isms. What I try to do, and that's through the caucuses I'm a part of, the legislation I introduce, the panels I'm a part of, is to say, this is a public health crisis. We've seen the numbers as described here, just a staggering number of lives lost, more than 1 million lives lost, 112,000 one year, down into the 80,000s. I call that a jetliner a day. Every single day, Monday, Tuesday, Wednesday, 365, a couple hundred people are dying in this country. What have we done in the past when 2 jetliners crashed, killing hundreds of people? The industry and the airlines grounded the planes. So we have to do everything, whether it's through advocacy and work, whether it's public policy, to ground that plane, to ground those planes every single day. Look for the wins in the number reduction last year, the 12-month number reduction of 30 or more thousand souls saved. What caused some of those wins? And I'm certain it's education, it's prevention, it's harm reduction. We have to destigmatize harm reduction. Harry and I were on a panel, or you moderated the panel, Harry, where a terrific clinician, physician said, I have not figured out how to treat a dead person. So why don't we keep saving them as many times as we can until they become prepared or ready or maybe willing and able to get toward recovery. So education, prevention, harm reduction, effective treatment, access to that treatment for all. We lived a life where when I finally figured out what was going on and going so terribly wrong with Harry, he was sick. We were fighting all the time. It was a miserable existence personally for him, but certainly for our greater family. I knew I was going to fight for his treatment. And if I had to go into debt to do it, we were going to do it. But I also knew in that moment, I was among the lucky ones because I could do that. I could fight for his treatment. I've seen and met too many mothers who struggled to get their child to treatment, were blocked, denied access, and their child didn't make it. Their young adults didn't make it. So we have to make it accessible to everybody. And finally, I'll end on, let's work with the policies and programs that work. I bet everybody on this line saw the article yesterday in the New York Times that the Trump administration abruptly cuts billions from state health services, and that includes addiction treatment. Billions of dollars suddenly cut off. I literally texted with our governor, forgive me, Governor Shapiro, to say, what notice have you gotten and what impact will it have? And they are giving us that information. Cutting off known grants and programs that are working. I think everybody on this panel agrees we're not doing enough. We're not reaching enough. And yet we'll cut off the very programs that are beginning to reach and beginning to bring those numbers down and get more people into recovery. It's the absolute wrong way to go. The reduction of dollars for SAMHSA, the reduction of even having an office within the White House that cares about mental health and addiction and opioid overdose. So we're going in the wrong direction, none of you, but I keep fighting here to say there are things we can do. We can see the differences. Lives can be saved. So let's get smart about it and stop being so bigoted against those who are struggling with the disease of addiction.
Thank you very much for those comments and for highlighting these incredible palpable inequalities, and also the need to expand our approach and not retract it. Let me turn to you, sort of on that note, Dr. McKinney. You talk about the ways that local governments and community organizations have not done enough to adequately address this crisis, both in Kensington and more generally. Can you say a little more about what you think is needed to manage the crisis in a community like Kensington?
Not done enough. I would say they haven't done the right things, right? There's a lot of efforts. They're the wrong efforts most of the time. We're still very much, again, in this either or sort of situation. And in each one of them, because when we think about harm reduction, we also have to think about harm reduction for the rest of the whole community, right? Because we are all one community. And the reality is what comes with some of this is increase in violence and increase in all sorts of different traumatic events. We think about ACEs scores going through the roof with children, all of those. So when we have a strategy, we need to be able to, just as we look and say, here is the harm reduction strategy for those that are struggling with addiction, we also be able, that same person needs to be able to hold up a list of what is a harm reduction strategy for the larger community, right? So that's just one piece of it. I think the challenge, again, that we're facing a lot of the time is that the extremists on both ends have won. And that is sometimes, is what we're looking at in America a lot of the time as well. And when the extremist wins, it becomes it's an all or nothing again, right? It's a zero-sum game. Now, I'm operating from a space that is extreme, right? Like a lot of folks are not seeing it in the same way that I am, of hundreds and hundreds of people literally in the streets dying, and within the, I think, second poorest congressional district in Pennsylvania, the highest rates of violence within the city, which therefore for a major city within the country. So the impact is hitting everybody, right? And it becomes either we got to get rid of them or get rid of them, right? And that is not a strategy from a government standpoint, from a local government standpoint. The politics is sometimes very simple, which is that where is all this happening again? In a space where no one votes, right? So how much do people really care about Kensington from a political standpoint when we have the lowest voting rates within the city as well, right? That is a very real thing. When we think about the issues, they become so politicized that it's one of these things that it has to be dealt with, right? Because it's become a national issue. But at the same time, it isn't really something someone wants to deal with, right? Our Kensington is made up of essentially four council districts, for instance. We're the tiny corner of four different districts, and we're the biggest problem in their district, right? Do you think folks really want to deal with that? So that's another piece. I think about, folks have been saying about science, like, because the solutions also, they lie in science. I'm a scientist, right? I believe in science. But I remember, 3 years ago, I wrote an op-ed right after the city announced that there was beginning to be a decline in the numbers of overdose deaths, and we're celebrating that decline. And I wrote an op-ed that pointed out that the numbers were increasing for Black and brown folks. And the administration at the time demanded a retraction from the paper, and they got it. They got a retraction to pull the exact statement they said. I put a quote from them in there. And so I say that is politics, right? Because at the end of the day, also, we're in a space, as those numbers increase, right? As those numbers are increasing for Black and brown folks, it's as compassion fatigue is setting in the communities that are dealing with this at the most. And the reality is you have Black and brown folks suffering more, and you have that compassion fatigue setting in. And I don't have to explain it to folks. Folks generally don't care as much that Black and brown folks are dying out there, right? I'm going to say that out loud, right? That is a different call to action. I'm old enough. I've lived through the crack epidemic. There was not a lot of sympathy. There was not a lot of compassion back then. As our congressman just stated, we cannot be in a space that we think we're going to solve this through criminalization of a health issue. This is insane. You know, what we're even beginning to look at. So I'm going all over the place, but where I'm landing is that science matters. It is telling us different things. A lot of the time right now, we're staring at, again, decreases in violence in the communities and decrease in overdoses. I'm going to use those as like proxies sort of for community and for folks who are in addiction. Folks are not able to identify right now exactly why that's happening, right? There is some stuff, there's a change in supply, there's a whole bunch of different pieces, but folks are sort of just patting themselves on the back a lot of the time that are in some of the political spaces. And if they don't know why something's happening, it will repeat, right? We will be back. Kensington has gone through a wave every 5 to 7 years of everything getting solved, everyone, you know, applauding themselves, and then it comes back because no one ever actually identified what was going on. The other thing I would just point to, and I'll shut up, is that we need to start with, again, this piece of trauma. Like everybody connected to this, families, those who are actually directly in addiction, whatever it is, has been traumatized by what is going on out here. And when we start with a trauma-informed approach, we are addressing these pieces that include addressing stigma, that include addressing all of the impacts that are happening on people that then lead to poor solutions, poor decision-making. When I am in a trauma state, I make poor decisions for myself and for everyone around me, right? We need to start from there, and we need to be able to, you know, work from that perspective. We also need to make sure that, as I've been saying, all solutions are comprehensive in nature, right? When we're thinking about anything from health, we're looking at all the social determinants of health that impact the situation. We have to be able to come at it from there, and we can't, again, do this thing where we're either going to solve this or that. Everything is intertwined. Everything is intertwined. There is no silver bullet for this situation. And the last thing I would say is that we need to make sure that everything is participatory in how we're developing solutions. And I say that from the experts need to be at the table. Sometimes it's someone sitting in a power seat. Sometimes it's somebody who was just living in the street, right? And understands what's actually going on. Everyone needs to be at the table when we're making the decisions and trying to understand what is actually going on. And when we think about that, we even need to think about that with funding and so forth. Again, we're talking, I am gonna harp on this piece of like, the numbers are going up for Black and brown folks. The funding that what little still exists is generally still going to white-led organizations. At some point, we need to identify where the disparities are, and we need to target them, and we need to be able to put resources behind them, and we need to increase voice for those that are most impacted.
Thank you. I mean, you mentioned that you were saying many things, but I think your point is really clear. This does have to be a holistic approach to get at all of these root causes and all these forms of inequality. So thank you for your thoughts on that. You talk a lot in your essay about harm reduction and about like sort of extreme views on harm reduction. And I'm going to turn to Dr. Stahler to talk a little bit more about the controversies around harm reduction. So can you talk about these debates around opening safe injection sites, needle exchanges, and other kinds of interventions that we might call harm reduction? Why are these programs so controversial? And do you think they offer a path towards addressing the crisis?
Before I answer that question, I just want to thank Harry and Congresswoman Dean and also Dr. Belenko around their work in the criminal legal system. It's so easy to forget the people who are incarcerated and not remember that hundreds of thousands of people will return to our communities, and many of those will have an addiction. And if it's not dealt with in prison, then you're really setting up a very unfortunate situation. I taught for 20 years in the Inside Out Prison Exchange Program in various prisons, and the people who are incarcerated are pretty much like anybody else, except that they tend to be poor and often, people of color. But it's so important not to forget about these individuals and to figure out how to best support them around recovery. So I'll just go back to your question, Judith. So harm reduction, I thought Dr. Brown made a terrific description about what harm reduction is, and yet there's a whole array of different harm reduction types of interventions, some of which are more controversial than others. I was very heartened to see in the Biden administration's national drug control strategy, they had a very prominent place for harm reduction, promoting harm reduction. And for the past, decade, there's been a real movement towards a greater acceptance of it. And I'm not so sure that's continuing, obviously. I think one of the most concerning things I've seen recently was in West Virginia, a state senator introduced a bill that not only would make syringe services programs illegal, and bring back mandatory minimums, but also make illegal opioid treatment programs that dispense methadone. I'm hoping this is not a trend or that it gets passed, but we're in troubled waters, I suppose. And hearing Congresswoman Dean's mention of what just happened yesterday is really extremely frightening. So I think harm reduction, in a sense, can be somewhat counterintuitive at first blush, right? So, you think about, does providing sterile syringes, does it enable or encourage people to continue to use? You're not curing the problem, so to speak. And it's sort of similar if you have a teenage child who is engaging in drinking, but you want to make sure that they are safe and don't drive, and you go and pick them and their intoxicated friends up at the party. Are you encouraging their drinking, or are you making sure that they are safe and aren't causing, greater problems? And that's in essence what harm reduction is. If you're a parent of a son or daughter who's addicted to opioids, yes, you would love for them to get into treatment. You would love for them to be abstinent, but you want to keep them alive until they can get the help they need, right? You want them not to acquire HIV or hepatitis as a result of sharing needles. So that's what harm reduction is. Some of the more controversial interventions have to do with safe injection sites or overdose prevention sites. And they are very controversial. There's been a ton of research done in other countries. A lot of this is that they found that a lot of the fears around these, what would happen, there'd be increased drug use in the area, increased criminal, assaults, etc. That didn't happen. Then what happened was, around the safe injection sites, was more people got into treatment. There was reduction in HIV and hepatitis rates. People were able to have low barrier entry into treatment, and it had very much very positive effects, unlike the fears. I think someone mentioned heroin maintenance. So it's true that not everyone is going to want to go to treatment, will do well in treatment, or they may choose to continue to use, but you want to save them. You can't treat somebody who's dead, obviously. And so it makes a lot of countries offer for those people who cannot, who do not want to go into treatment, who have failed treatment, they maintain them on, pharmaceutical grade heroin, essentially, and for a while until they're ready and they decide to go into treatment. So I think part of the problem around, harm reduction is that there's a lot of fears and around what it is, and also that it's not the total solution to the problem, but it is definitely a path towards addressing part of the problem. You want to keep people safe. You want to keep them alive.
Thank you. So that you mentioned Dr. Brown's earlier comments, and I want to go back to you, Dr. Brown, to talk a little bit more. You talk in your essay very movingly about some of your personal experiences, the tragic opioid-related death of your close high school friend, your work, and also your work as a social work clinician. And you discuss how these personal experiences kind of led to an evolution in how you thought about appropriate treatments, particularly the use of medications for treatment. So can you talk a little bit about that evolution? And can you talk more broadly, and here I promised we would get back to stigma, about how you see stigma as a way, as getting in the way of effective treatment?
So I spent about a decade working in community mental health as a case manager, and then later as a licensed clinical social worker. And I worked in rural and remote areas of East Tennessee. When I was entering into practice as a LCSW right after the recession in 2000. I graduated in 2010, and so to get my first job as a therapist, they kind of roped me into working in two different offices, and one of those offices was in Madisonville, Tennessee, and it's a very small town in sort of the foothills of Appalachia, not far from Dollywood, probably like an hour from there. And so, and I'd never been there before the first day I show up to the office. But by the time I finished, I left, 7 years later, I was working there like most of the time. That ended up being kind of my primary location. And so, as you mentioned, my attitudes towards treatments for addiction in general, and specifically opioid addiction, changed during that time. I didn't go into practice really planning to focus on treating addictions, but when you work in a rural place like that, you wear a lot of hats, and you kind of have to meet the needs that are brought to you. So during that time, my attitudes changed, and I also saw how stigma is not only perpetuated by the public, but also by health and human service professionals. And I saw how particularly people who are on taking methadone and buprenorphine, how the nurse practitioners and the other therapists in that clinic would talk down about them behind their back, right? And maybe there were parents just trying to work towards their permanency plan and driving an hour and a half each day to get methadone in a different state because it wasn't offered there, right? And I saw how they talked about those parents like they weren't doing the very best that they could, right? And so my focus in research, one of my sort of first focuses, and I'm kind of branching out into other areas now, but has been to learn how to change attitudes towards harm reduction among health professionals, and specifically non-prescribing clinicians like myself. And because there has been a lot of work with prescribers to get them to be more willing to prescribe buprenorphine in these communities. And so attitudes that can be pretty entrenched. And I guess I was sort of, using myself as a test case of like seeing how my own attitudes changed over time, and how I could replicate that and study that in other clinicians. And so those attitudes can be entrenched. It's not easy to change them. But I believe, my attitudes changed because of my lived experiences, because of, as you mentioned, losing a friend, and losing multiple friends to opioid addiction, and also from my practice in those communities. And so early in my career as a clinician, I was supportive of buprenorphine and methadone treatment. I certainly believed they should be treatment options, but I had a lot of misconceptions about how those medicines should be used. And in my research, I see that a lot. Like, I see that in general, if you ask clinicians whether they support medications for opioid use disorder, they'll probably, categorically say that they support it, but when you dig down into it, they still have a lot of misconceptions about and misgivings about how it should be used, right? And those relate to your treatment orientation. And so at the time, I believed that abstinence should be the primary goal of addiction treatment. And so, and I think it certainly can be a goal for, and it is a worthwhile goal for people who want to achieve those goals. But as a clinician, I know that when I work with people, if I have a different goal for that person than they have for themselves, it's not going to work, right? Like, there has to be an alignment and we have to we have to work together towards agreed upon goals, right? So like many clinicians, I believe that medications for opioid use disorder should be offered short term as a pathway towards abstinence. They call that tapering and withdrawal. It wasn't until I worked with people who relied on long-term medications, and I write about that in the essay, that I truly began to understand that taking buprenorphine or methadone for a long time, talking, that person I wrote about had been on it for over a decade. It's not a failure or compromise, but rather it can be a highly effective approach to recovery. And that is for that person to determine what works for them and what is going to keep them safe, right? And so as a clinician, I seek to support people in whatever's going to be work for them, right? And so there's no reason to take someone off of medications early just because we have some belief that that's like the way they should work, when research really shows that that's not how they work best, right? So what I've learned from all those experiences, as well as my research, is that knowledge alone is not typically enough to change attitudes, that we can't just do training and learn about these medications and harm reduction strategies and that be enough. People need to hear from people who use drugs that have benefited from treatment and from harm reduction strategies. And when people share about these experiences with their drug use and recovery, I think that's what can help change attitudes and reduce stigma. And as I was talking about earlier, I think that's what we've seen across the nation, that at least I believe that people are more open to treatments that work and harm reduction than they were a decade ago. But yeah, I hope that we don't, regress too much in the coming years. And we, as we've talked about, that we've seen declines and some improvements, and that's great. But way too many people are still dying and are still affected by this. And so it's not time to pull back on our prevention and intervention efforts.
Thanks so much. I just want to make sure I understand one aspect of what you said. You talked about non-prescribing professionals like social workers, psychologists, nurses, maybe. And am I right in understanding that what you're saying is that the attitudes of those professionals matter in part, they matter for a lot of reasons, but in part because they're gatekeepers towards medication? They're not prescribing it, but that they are gatekeepers towards referrals, towards physicians, etc. Is that what you were sort of getting at?
Yeah, and I think as I mentioned, like, there's been a lot of attention paid towards prescribers, as they should be, right? Because like there's been a lot of efforts in the last couple of decades, particularly with buprenorphine, which was first in the mid 2000s, early 2000s was when it was first approved for treatment of opioid use disorder. And we don't have office-based methadone in the United States like they do in Canada and some other countries. So, getting methadone is really hard. And so buprenorphine is much more like a normal medication that you can just go get prescribed and like get it at your pharmacy. And there's a lot we could talk about with that too. But so prescribers, obviously are an important group to target, to prescribe, and to increase the utilization of buprenorphine. But non-prescribing clinicians matter too. And I think that I think particularly in rural communities like where I worked, you know, I worked in community mental health, and in those counties where I worked, we were one of, if not the only places you could seek treatment. We didn't specialize. We weren't focused in like completely just on substance use disorders. We really mostly did mental health, but we also treated a lot of addiction. And so I would often have people come to me for an assessment, and I'd be the first person they were interacting with when they were seeking treatment, seeking recovery, right? And this is a big step they're taking to seek recovery. And so, at that time, I'm making treatment recommendations, I'm making referrals. And if I'm not telling them about the various physicians in the county I know that will prescribe them buprenorphine, and if that is an option for them, then they're not probably going to know about that, right? And so, yeah, so I think non-prescribing clinicians do matter a lot, and so that's been one of my focuses, is trying to train and study non-prescribing clinicians to see how they can make a difference. And really, I think people should have a menu of treatment options available to them. Like if they want to seek rehab and do residential treatment, that's great. They should be able to do that. But they should also have the availability of medications if they want to. And I'll just say just quickly, this is specific, I think, to rural areas and in the South in particular. I grew up, my parents were professionals, and I was pretty sheltered. And so it was really surprising to me when I first started practicing in Madisonville to learn about some of the largest employers in the county. We don't have unions. We have right to work laws. And it was surprising to me to learn about people that were coming to me for addiction treatment, taking opioids. And then really a lot of them were just maintaining, right, and trying to, just taking daily, but generally functioning pretty well, working. And they would not get a day off for weeks at a time. They'd go weeks at a time without a day off. They certainly couldn't take vacations. And so to tell them that they have to go detox for several days inpatient and go to rehab for a month, it's just not feasible. Like, they're not going to come back to a job that's there anymore, right? And they have a family they're taking care of. And so anyhow, so that's another reason why I believe that, we need treatment options available. And non-prescribing clinicians, I think, play an important role of that as well. So.
Great, thank you. We still have some time. We're running a little tight on time, but I really just want to hit two more questions about stigma quickly. Dr. Belenko, you talk about stigma in terms of individuals accessing treatment who are involved with the criminal legal system, both inside and outside of incarceration. How might our justice systems be reoriented to help people towards recovery and reintegration in their communities, given this barrier of stigma?
Yeah, that's a big question. I'll try to be brief. Certainly stigma is part of it, but also we have organizational, systemic disparities in resources. We have two systems, the treatment system and the criminal legal system, that are siloed, that don't interact, that don't collaborate, that don't communicate effectively. So one thing, I've done several projects where I've brought criminal legal system staff and treatment staff together to work collaboratively to solve problems with a coach or a facilitator, using data-driven decision-making to understand what their processes are, how they exist in terms of identifying people with substance use disorders, particularly opioids, identifying potential places to link them to treatment, working collaboratively between criminal legal staff and treatment staff to make the best referral possible, and then communicate progress back and forth. So they understand each other, and it's been effective in helping different systems get out of their comfort zone, understand each other, understand the different languages that are used, and that they're working towards a common goal. Imagine a system, and most people in criminal legal supervision are in the community. They're on probation or parole, more so than incarcerated. Imagine a system where the staff, half of their people they're supposed to be supervising or helping successfully complete probation or parole. Imagine a system where half of them have a substance use disorder, 20% have opioid disorder. If they get know absolutely nothing about addiction, know nothing about treatment, are not trained in it. It's not part of their jobs to do that by and large. So we have so much to do, and echoing Dr. Brown's comment, it's not just training itself or providing knowledge is important, but it's not sufficient. You have to change attitudes. You have to open up people to other points of view, to other ways of looking at public safety and how public health and public safety are so closely intertwined. And that can be done, bringing people with lived experience to work with criminal legal staff, understanding on the treatment side, having them understand the impact of public safety and the need to protect public safety, as well as trying to help people get rehabilitation. And then finally, just again, coming back to the lack of treatment linkage and effective treatment linkage throughout the system. That needs to happen before incarceration. We need to have early intervention. Someone has contact with the legal system. We do have mechanisms, we have programs that can get, even involving police, that can steer them into treatment with cooperation of social workers and community mental health workers to get them into the treatment door rather than the criminal legal system door, which is so counterproductive. It's so much research that shows that treatment is much more cost effective than anything the criminal legal system is going to do. So you spend $1 on treatment and the payback is much greater than what we're doing now. So I think the training, developing collaborative projects, bridging that gap between treatment systems and public health and the criminal legal system, changing those attitudes, involving people who are affected by the system is crucial. Whether it's peer recovery support specialists or people with lived experience coming in and talking with staff, overcoming that stigma is very important.
Thank you. And Congresswoman Dean and Mr. Cunnane, you in your beautiful book show how stigma prevents families from seeking the help that they need for their loved ones. And you write, it's only when our public policies meet our shared humanity that we'll get this right. So is there a role for policy to reduce stigma so families get the help that they need?
I should have at the beginning, Judith said, call me Mad and Harry. Thank you. Because I do want to set the stage here that when Harry and I, and by the way, it was a whole family. It's not just, even though Harry and I are the co-authors of the memoir, as my husband says, I was there too. It's a family issue. It's a family disease. And so when we were going through this, the final years up until the moment that Harry went for the beginning of treatment and detoxing, I was not an elected person. We were a lucky suburban Philadelphia family of 5, 3 boys, Harry the middle one, and loving parents who were very in the dark in some things that we had to learn the hard way along the way. So it wasn't until later that I got into public life, elected office. But I will tell you, our experience and just seeing the suffering of other families motivates what I do as an elected official. But I did want to set that stage. I wasn't a congresswoman when this was all going on. 2 things that I wanted to say about policy, and then I'll toss it to Harry because I think he'll have better things to say. It is about our common humanity. If we cannot see whether the person is a person of color or the person is male or female or LGBTQ, poor, middle class, well off, if we can't see the common humanity in the person struggling with the disease of addiction, in the addict, I'm a person who cares about words. That's a very harsh word. It's hard for a mom to say my son is an addict, but if we can't see the common humanity, we're never going to get this right through policy. So 2 policy points that I want to point out. Dr. McKinney, you were talking about the science, the research. I'm gravely concerned that research will take a real deep set of steps back. I've been to NIH. This is prior to this administration returning. the important research being done on the disease of addiction, on the brain, is going to suffer greatly if these slashes to research and to our universities actually takes hold. So I'm super worried about that. The second policy issue I'm very worried about, and this is all very timely, sadly, is Medicaid and the threatened deep cuts to Medicaid. In Pennsylvania, a simple number that reveals great humanity: 100,000 Pennsylvanians receive treatment for addiction, opioid and other addiction, through Medicaid. The Medicaid is an investment in our communities, not just in treatment for addiction, but in, taking care of our elderly, children, pregnant mothers, little children. Medicaid is an investment in our community. And if we somehow slash that, of course, mental health will be harmed, physical health will be harmed. And who and where are we going to pick up the slack? Who's going to see the humanity in that person that winds up back in Kensington using, because that treatment was cut off, their ability to move forward, to keep that job and take care of their family is cut off. So between research and the basic, valuable, powerful work of Medicaid, those are two policies that I hope we don't backpedal on, as is very gravely threatened. But I'll give it to you, Harry.
I think we're out of time, so I'll go really quick. I fully agree with you on those two pieces, but as I'm thinking about stigma, and I'm thinking about this conversation, I think policy absolutely plays a role. But I think things like this, right? I think I'm a person in recovery. I've worked in the treatment space. I have a communications firm that works with organizations that come out of different, whether it's harm reduction or other areas of this. I think, those of us doing this work really need to do a much better job, of not stigmatizing these other pieces. Dr. McKinney talked about it's a holistic, there's no one answer. We need harm reduction, we need treatment, we need prevention, we need recovery supports, we need the criminal justice system. We need all of these things working together. And I think if we want to make policy changes, we can't be, battling it out with each other. We need to have more of a unified, front and understanding that all of these pieces are critical, right? There is no one silver bullet on this thing. We need all of it, because people access care at all of these different levels, whatever that may look like. But to wrap up, more than anything else, I think, in order to do that, we just need to continue to see the humanity in these numbers. They're horrifying. We need to call out, where the disparities are, where the inequities are. But we need to know that we're talking about people. We're talking about people that we love and we care about and are in our communities. And it is a disservice to all of us, if we kind of, write that off. But, the impact that we can make from a policy standpoint is significant. Yes, celebrate some of the wins, recognize where we're not winning yet, double down. And I appreciate, the timing of this panel, because there is a lot that's on the table right now. And there are areas that we could have some, significant backslide. So I think it's important that we're coming together and we're having these conversations. So thank you.
Well, thank you.
1 minute over.
Only 1 minute. Thank you. That is a really important note to end on. I'm so sorry we're out of time. This conversation obviously could go on for a long time and should continue in many different venues. Thank you so much to each of the panelists for your thoughts and for your essays. And I encourage people to read the magazine. And I thank you to the Dean Deeg and the CLA Dean's Office for your support of PPL. Thank you all so much. I wish everyone a good afternoon. And that concludes our webinar. Thank you.
Thank you.